My name is Julie Didkowski, and I'm one of the 5 National Referral Relations representatives here at Skyland Trail. I live in Atlanta, not too far from the Skyland Trail campuses. Before we get started, I'd like to tell you a little bit about us. As many of you know, we are a nationally recognized nonprofit mental health treatment organization. We specialize in treating adolescents and adults who have a primary psychiatric diagnosis through our residential and day treatment programs. Our adult program has 4 psychiatric recovery teams: CBT, intensive DBT, first episode psychosis and cognition, and also social integration. We do offer a co-area of focus in dual diagnosis for individuals who are in recovery from a substance use disorder. Our adolescent program treats teens who have a primary mood or anxiety disorder and has 2 tracks, CBT and intensive DBT. We also now can work with adolescents who have secondary mild to moderate substance use, as well as secondary PTSD. And we're really excited to announce that we can now take direct admits to our adolescent day treatment or PHP program, just as we do for our adult program. You can find more information about our programs and services, as well as our evidence-based and holistic treatment model on our website at skylandtrail.org. Thanks again for coming. And now it's my pleasure to turn it over to Molly Mercer-Dedman, our Education Director, who is going to introduce our speaker for today. Thanks so much.
Thank you, Julie. First, I want to go over some housekeeping items. So you must attend the duration of the presentation today in order to earn continuing education credits. After the event, you'll receive a personalized link to your attendee dashboard hosted on the CEGO website. On the CEGO dashboard, you'll be able to complete the evaluation form and download your CE certificate immediately. Note that this is a Zoom webinar, so please use the Q&A box for questions throughout the presentation. Dr. Hunter is going to leave time at the end to get to those. So again, I might not be able to see all the questions in the chat box, so please put it in the Q&A. These slides will not be distributed, but a recording of the video will be available on Skyland's website after the recording today. So it's my pleasure to introduce our speaker, Dr. Ben Hunter. Dr. Ben Hunter is the Interim Chief Medical Officer at Skyland Trail. In this role, Dr. Hunter manages psychiatric services, transcranial magnetic stimulation, psychological testing, and family therapy, nursing, and the integrated primary care function. Dr. Hunter completed his medical training at Emory University and a psychiatric residency at the University of Pennsylvania, where he served as chief resident during his final year. Additionally, Dr. Hunter completed fellowships in psychoanalysis and organizational psychiatry through the Psychoanalytic Center of Philadelphia. Dr. Hunter was elected a Fellow of the American Psychiatric Association in 2023 and is Vice President of the Georgia Psychiatric Physicians Association. Welcome, Dr. Hunter.
Yeah, thanks so much, Molly and Julie, and thanks to everyone for a great turnout for this discussion today. I think that Skyland Trail has been such a wonderful place to work. We've had an approach that really drew me in from day one. This idea of holistic care, of whole body, whole brain health, and kind of integrating those things to really help patients change their life in a meaningful and lasting way. And that's why I'm at Skyland Trail. I'm really excited to talk to you today about a topic that has become more and more critical to our Skyland Trail programs as the years have gone on, and frankly just becomes more widely used and more widely appreciated across psychiatry in transcranial magnetic stimulation. So we're going to talk today about a relatively new, very high-tech, very evidence-based treatment that has offered hope and healing for patients who have really struggled to get the response they want with medications and psychotherapy. So again, these patients who have been deemed somewhat treatment resistant have responded to TMS in a way that has been really game-changing for their care and for their lives overall. So again, very excited to talk to you about this and help you understand where this may fit into your patients or your loved ones' treatment paradigm. So first, as always, disclosures. So none relevant to this talk today. I am on the Clinical TMS Society. insurance committee, so I do lobby for better insurance coverage for TMS with some of the insurance companies, but no personal financial conflicts or none for Skyland Trail. Just a quick note before we get started. You all heard Molly mention a bit about my training. I will tell you that I came to psychiatry largely because I find the idea of psychotherapy and healing through narrative to be the most compelling component of mental health. I know that at this point, especially with some of the newer, higher tech treatments and psychedelics and all these things that are coming to the forefront of media and research, we tend to focus a bit on these interventions and sometimes probably confuse them with, the actual agent of change. I think, and I shouldn't say I think, what we know, psychiatrically speaking, is that these treatments are incredibly effective at promoting stability for patients, reducing symptoms, and allowing them to get to a position where they can make change. But TMS, ketamine, MDMA, Zoloft, all these things that we know have evidence to work for depression, anxiety, and a variety of other conditions are not the change themselves. They are the vehicle to change. What we believe very deeply at Skyland Trail, and again is an evidence-based belief at this point, is that lasting wellness and fulfillment are driven by this process of promoting internal awareness, developing a more accurate and compassionate narrative, both to ourselves and to others, to the community, sort of the world at large. And we know that we have to understand our experience and its connection to humanity and just humanity over time to really truly live our greatest life. So I want to provide that context here. I'm a psychiatrist. What psychiatrists typically do is medications and other kind of medical treatments, but we really view at Skyland Trail, and my personal belief is that the psychotherapy component, that component of again, developing this story about ourselves and kind of understanding what it means and how we can adjust that slightly to understand ourselves more effectively is really what the change is about. So this is, TMS is one of the best treatments we have right now to get people to a place where they can do the work that will change their lives in a permanent way. So just a quick outline here. We'll talk about why we need TMS or other neuromodulation procedures in the first place. We'll talk a bit about the history and the science behind TMS. We'll look at kind of an ideal TMS patient, what patients are eligible, what patients are likely to benefit. Who's not a good TMS patient too is always part of the question, because when the results are as great as they are, you kind of do need to know why some people unfortunately can't have TMS. We'll talk about the actual TMS experience and what a patient will go through and what that process is like, and look at some future directions where there's current research and ongoing research about new treatment modalities, different diseases we can treat with TMS, other uses for TMS going forward. Again, kind of defining neuromodulation. So neuromodulation is a blanket term that's encompasses both non-invasive and invasive techniques. And the idea with neuromodulation is that rather than something like a medication or psychotherapy where we're sort of secondarily affecting the brain via the whole body distribution of an SSRI, or we're kind of secondarily affecting neurochemistry by speaking with someone in psychotherapy, these are direct stimulatory or inhibitory treatments that are designed to hit specific nerves or networks of nerves that we know are implicated in a disease process. And the goal is to modulate those pathways and correct abnormal physiology, return people to their baseline functioning, their non-pathological functioning, or in some cases to move people to a new level of functioning that they hadn't previously achieved. Examples of neuromodulation include TMS, obviously, direct current stimulation, which is becoming more popular with some home devices that people can buy, frankly, without a prescription. Efficacies, I think still a work in progress there, but certainly some promise. Deep brain stimulation, where electrodes are actually implanted in the brain and directly deliver electrical current to various specialized spots in the brain. That is actually very comparable to TMS in a way. Again, we are also delivering electrical current with TMS, just a little bit less directly than if you actually had neurosurgery, of course. Vagal nerve stimulation, where we put a stimulator on the vagus nerve to modulate the parasympathetic and sympathetic tone and therefore affect mood and anxiety that way. And then things like spinal cord stimulators for pain conditions, where we know that stimulating areas in the spine can affect full body pain. We also typically include electroconvulsive therapy in this. While electroconvulsive therapy is not quite as targeted, and that in this procedure we induce a generalized seizure, and then the seizure creates the therapeutic effect. electroconvulsive therapy is something I always touch on whenever I'm talking about TMS, because it's one of the most underappreciated, underutilized treatments we have in medicine as a whole. It's a life-saving treatment for many people. Again, it's gotten a bad rap from movies like One Flew Over the Cuckoo's Nest, but it is, again, a very safe, very humane, very effective treatment, albeit with more side effects than TMS, and therefore often not the first or second line move for someone who hasn't responded to their antidepressant medications and therapy. But I do want everyone to walk away from this having heard one more psychiatrist say that electroconvulsive therapy is an incredibly effective and safe treatment that should be considered for many patients who have not responded to treatments like meds and TMS. Moving along here. So, why do we need neuromodulation procedures? I don't think this is going to be a surprise to anyone in this webinar right now. Depression is unfortunately a condition that is becoming more and more prevalent in the United States and in the world. It is something that creates an incredible amount of disability in people across the world, and it seems to be getting worse by the year. I have a lot of thoughts about why that is. I think this is something that psychiatrists and mental health professionals talk about ad nauseum. Frankly, probably would fill an entire second webinar just talking about why we think depression is getting worse, other mental health conditions are getting worse. But the bottom line is that we're seeing more people depressed, more of the population. We're seeing a higher level of severity, and we're seeing more people who are coming to us in a quote unquote treatment resistant condition where they've tried multiple medications and other therapies and have not reached the point of remission of their depressive symptoms as we would typically expect. We know from classic studies like STAR-D and the subsequent analyses of the data from STAR-D that up to 20-30% of patients with depression will not respond after 2 medication trials of adequate dose and duration. And in that large, massive study, actually, groundbreaking study, over 30% of the patients who came to that study depressed were not able to achieve remission of their symptoms after all 4 treatment steps. And that includes multiple steps of escalating strengths of medications, adjunctive medications, cognitive behavioral therapy, and even moving into combinations of medications that often aren't even used for depression, sort of like thyroid hormone and other treatments that are really third, fourth line, up to MAOI medications and others that we rarely see in clinical practice. Even with all those weapons pulled out of the armamentarium, up to 30% of people were not able to achieve remission. So that is obviously a huge percentage. We know that these patients with treatment-resistant depression have lower productivity in their lives, higher medical comorbidity, which is a huge issue that we're appreciating more and more as the years go on. Again, that connection between mental health issues and general physical health issues. And we know that they have more suicide attempts. And obviously suicide is the most concerning of all the outcomes of depression, and one that we try to prevent at all costs. And again, we know that people who have failed multiple trials both become hopeless, but also become harder to treat and often experience more severe symptoms that lead to suicidal thinking and unfortunately suicide. Again, issues with traditional medications and therapies are a big reason why we need neuromodulation. So again, as I mentioned, lack of efficacy is a major concern. You see an outline of the different treatments we were just discussing here, the different levels of the STAR-D study, and you can see the remission rate, which is again, essentially low-level symptoms, is essentially clinically negligible depression sustained at a year. Again, about a quarter of people will get better. All comers will get better if they just walk in and try one SSRI. You're down to 14% of those people once you've had to add on another medication or switch or add psychotherapy. By the time you get out to level 3 and 4, where you're trying tricyclic antidepressants or lithium or thyroid hormone as augmentation, or you're switching to an MAOI medication at level 4, look at how low those numbers are. This is a really concerning and unfortunately a really pessimistic prognosis for people who have failed multiple medications and therapies. And again, we know that even beyond just the failure to get better with these medications, even when people do respond to them, they often have intolerable side effects or difficult to tolerate side effects. And again, by the time you're at tricyclic antidepressants and augmenting agents and MAOIs, you're at up to a quarter to a third of patients who are just unable to even tolerate the medication on a day-to-day basis. So unfortunately, even though an MAOI might be very effective, and they are for many patients, they're very hard to integrate into people's lives sometimes due to the side effects. The problem is medications are also non-targeted, and they do affect the whole body. They have to be processed through the sort of the general body metabolism, and therefore can affect organ systems other than the brain, of course. And this is an issue, particularly when you think about pregnant women, pregnant people, about children who are always worried about the effects of medications on children's bodies and brains as they're growing and developing in particular, and older adults who may have, more medical issues, maybe slightly more frail from a metabolic standpoint and just their ability to process medications. They often have more medications too. So all the other different medications we tend to accumulate over time as aging takes its toll. Those in combination with antidepressants and other medications can really create a situation that can be somewhat unsafe for patients, can lead to instability and all the different things that we worry about when we have polypharmacy with older patients. So it'd be great to be able to avoid those issues. One more really stark data point, and this study is one that has always stood out to me. Dunner and his team took a cohort of 124 community-based patients with treatment-resistant depression, and they just looked at these patients after 1 year, and all they were looking for was the number of patients, not who had necessarily sustained remission, again, meaning minimal symptoms, but those who were at least just 50% better than where they were at baseline. And this is based on validated depression scales. We ask patients how they're doing, and we take objective measures. They looked at a year out, and only 10% of those patients who had received standard major depressive disorder treatments were able to sustain a response at a year. So again, that's so tough to know that 50% of the people in this study who, again, this is a real world type scenario, 50% were still no more than half better than when they started is just a really rough data point to check. And again, just insinuates why we need better treatments. We need treatments that are more effective, that last longer, have fewer side effects. And again, we need to be able to use them in all populations. I think there's these groups like, again, people who are pregnant and children and older folks, people with unique medical challenges. We would love to have a treatment that doesn't have to be passed through the entire body to process. Again, psychotherapy is a great example of something that doesn't require quite as much, systemic, obviously, involvement. But at the same time, we know that for many people, there is a biological component that we need to address in order to give them a fair chance at getting better too. So these are in combination with psychotherapy, of course, and that's where we come to TMS. So quick view here, and everybody can kind of sink this into their minds as we go forward. This is actually our Skyland Trail TMS room. So you've got what looks like a dental chair there on the left. The TMS machine itself on the right consists of essentially a computer hardware system that drives the magnet and provides all the different treatment settings, and then a computer interface where we enter patients' information and settings, and we track their treatment over time. That black sort of element connected to the hose there, that is the magnet itself. It's hard to tell from that angle, but it's shaped like a figure eight. It's actually two essentially circular coils attached, and that creates a conical magnetic field that we direct at the brain in a very specific spot to treat depression. We'll talk a little more about that. Just a brief overview of the history of TMS. One thing it's important to note is that TMS is not a brand new procedure. I think it's easy to see it that way because I think probably 2017, 2018 and beyond, you really started to see more clinics open up with TMS machines, and it became a little more widely accepted as a treatment. Insurance companies started to cover it a little more effectively, so more patients were able to get their hands on it. But this has been approved since 2008. So this goes all the way back to the 1800s. We started to understand, via Faraday's law and all the other physics equations that will haunt us, post-graduation high school and college. Faraday's law connected magnetic field and electrical current in a way that we know we can drive electrical current using a magnetic field. And that is the technology and principle we take advantage of in TMS. Sylvan Thompson in the early 1900s started to stimulate the brain using a magnetic field in what was a very uncontrolled way at the time, but again, great proof of concept. About 1985 or so, you started to have real proper attempts to use TMS as a therapy for mental health conditions. So Tony Barker and the group at MagStim really developed the first machine and were able to demonstrate that it could be used to affect mood and other systems in the brain. Again, FDA approved in 2008, so it's been around for 15 years now. Thousands and thousands of patients in clinical trials. This is a very safe and proven treatment. You've got a number of different machines that have been FDA approved. We'll talk a bit about these other technologies like theta burst and deep TMS as the talk goes on, but those just up there to show that the last few years have heralded a few new advances in TMS, and it's a really exciting future. It's currently one of the most researched areas in psychiatry and medicine as a whole. Again, thousands of ongoing research studies right now about TMS, how to use it more effectively, how to use it for different things that we haven't currently achieved FDA approval for, all those great things to help TMS move forward and help more people. Again, this is here's a better view of the magnet. You've got essentially a MRI strength magnet, 1.5 to 3 Tesla typically for these magnets, if you know your physics. That magnetic field induces electrical current, as we mentioned, and then the electrical current itself affects neurons in the limbic system. So neurons are brain cells, and the way those neurons fire, the rate at which they fire, the way systems of neurons communicate with each other is what we believe generates either mental health or mental illness, and again, just sort of dictates the functioning of our brain. It's no longer the neurotransmitters in a bag theory where, it just elevating serotonin levels will treat depression. We know that the effect of those serotonin reuptake inhibitors is more about the networks that they are able to impact and the way we can change the way these systems communicate internally in the brain in order to generate more positive emotions and more relevantly to avoid depression. The limbic system that we're affecting in TMS modulates mood, anxiety, and a number of other functions, including executive function like attention and concentration, focus, task switching, all the things that are associated typically with people's professional functioning largely, or also ADHD if it's in deficit. Again, magnetic field modulates electrical activity in the dorsolateral prefrontal cortex. So if you look at that figure, the blue area there is roughly where the dorsolateral prefrontal cortex lives. And what this is an access point to the limbic system. It's out there where we can get our magnet and get that magnetic force to it relatively conveniently. One of the things we have to do is pick areas in the brain that are relatively close to the surface, because it is not a painless experience to have electrical current delivered to the brain. Again, it's much more tolerable when you use magnetic force to induce it rather than just trying to pass electrical current directly through the skull. But there is still a sensation to this, and the less power we have to use, the better patients like the treatment. So the great thing about this area is that it's right out there on the cortex, right on the surface of the brain. Again, we know that based on a number of studies using functional magnetic resonance imaging and other technologies, that the left side of people's brain in that dorsolateral prefrontal cortex area is hypoactive in patients with depression. And therefore, to treat it, we will excite that area. And on the right side, there's hyperactivity. So we will actually use inhibitory protocols to treat that side. Again, you can really treat either or, and many people still do treat one side or the other. There's a lot of studies at this point that suggest that treating both sides actually has not a totally sort of combined additive effect, but a better effect than treating either side individually. So we do take advantage of that in our treatment. By depolarizing those neurons in a local spot, in the dorsolateral prefrontal cortex, we regulate pathways that mediate mood via the limbic system, as we mentioned. We know that activating the limbic system stimulates release of neurotransmitters like norepinephrine, serotonin, dopamine. Blood flow and glucose metabolism rise in those areas. This is fairly easy to demonstrate using neuroimaging. And this probably provides a bit of the short-term antidepressant effect. But what we also know is that, again, through neuroimaging, the change to the brain's internal connectivity and the way these systems in the brain communicate with each other is probably, putatively, almost certainly, what drives the long-term change that we see with TMS and with other treatments too. So, the question is always this: if we give someone, Prozac and SSRI, and we elevate their serotonin levels, that will happen virtually instantaneously. That happens within one dose. You can see an elevated serotonin at the synaptic cleft after a single dose of Zoloft or Prozac. So why don't people get better? The answer is that, again, that is a secondary effect. The getting better part is about those SSRIs or other medications or treatments, therapy, TMS, affecting the brain networks, kind of reprogramming them, which is a slower process. It's one that takes a bit of time to train in. And that's why it takes 3 to 4 weeks for a lot of the medications to work. It's why it takes that long for TMS to work too. Again, we know that it also improves, TMS improves GABAergic tone. So GABA is the inhibitory system in the brain. So talking about largely anxiety management and other sort of inhibitory functions that we want to be able to do in order to maintain mental health. Glutamatergic tone, which is an excitatory neurotransmitter as well. And then we know that it increases neuroplasticity. So again, through brain-derived neurotrophic factor and other elements of the brain's neurochemistry, we are able to induce a state in the brain that is prone to change, and that is typically and inherently a positive thing. We are able to help people encode memories differently in a way and change their narrative, as we were mentioning, through our psychotherapy efforts when the brain is more plastic. And again, this is something that is really kind of the holy grail of treatment for most mental health interventions is, again, treatments that increase plasticity, that allow change and pruning and improvement and development of the brain, both physically and in terms of the different ideas and memories and thoughts that are encoded in the brain. So TMS is really exciting in that it can induce that state. What you see here is some really fascinating and newer research from Goldstein-Pekarsky group out at Stanford. And again, this is just to the point that we were discussing earlier. How we are now understanding brain functioning and mental health is as a series of different networks in the brain, and you see some of the different connective elements here that are involved with these different brain circuits and the conditions that they are associated with. So again, just a map here, not meant to be exhaustive and frankly not worth explaining at this point, but just to show you that for something like negative affect or attention, there's a number of different areas in the brain that are sending signals back and forth, for lack of a better explanation. And the rate at which they do that, the degree to which those areas are connected, and the strength of those connections dictates how well or how poorly they function. And this is going to really change how we think about mental health, in particular with neuromodulation techniques, as we understand these networks better and understand our access points better. So moving into who TMS is for. So our good TMS candidates, the ones who we look at when they come in for a consultation, say this is really a great treatment for you, and you're likely to improve. They need to be currently depressed. Again, to first have TMS, and we'll talk more about maintenance TMS later. But when we think about people who are coming in for their first treatment, they are currently in the middle of a depressive episode, and insurance companies will dictate that it needs to be moderate to severe. And again, that's based on evidence-supported scales and validated scales that we use, like the PHQ-9 or the Beck Depression Inventory, Montgomery-Åsberg Depression Scale. Again, moderate to severe. And often, I will say, not to just throw the insurance companies under the bus too much, we don't think of TMS as a first-line treatment right now. And that's not because it's not safe and effective, because it is those things. It's because it does involve a lot more time and effort, and it's a little more expensive, and all these things that if we can get away with somebody doing really well on again Lexapro or Wellbutrin, that is often more convenient for them. It's frankly more sustainable for the system. So we're not telling people to come in the first time they have depressive symptoms. The FDA says you have to fail at least one medication during that episode. Insurance companies usually go out to a 2 medication trial requirement, and often of 2 different classes. So for example, an SSRI and then an SNRI, like Effexor or Cymbalta, Pristique. An SSRI plus an augmenting agent like Wellbutrin, Abilify, an antipsychotic. Some of those things you can combine can count. The key, though, is they do need to be adequate dose and duration. So, the first dose that most people start off with an antidepressant medication usually is not something that dictates that they've failed that medication. They need to titrate that medication, increase the dose over time to the point where we know that a more significant proportion of the population is likely to respond in terms of their depression symptoms. And that's what insurance companies will look at. It's frankly what I look at too. And it needs to be on board for at least a month to 6 weeks. Again, allowing the brain time to adapt at that effective dose. Some insurance companies will require more medications. Some will require psychotherapy, combinations of medications. We frankly describe these policies as out of date at this point. Again, I think the industry standard is 2 medication failures of 2 different types. Off-label treatments, though, again, when you have a safe treatment and that is very effective, often you use it in ways that are not approved by the FDA. We do this with medications all the time. We occasionally do it with therapy. Off-label treatments that we consider are for patients who just frankly don't want to use medications for religious or cultural reasons or otherwise, just history of poor response. for kids or for older adults who say, you know what, I know I'm going to have to pay for this, but I'd rather not subject myself to another medication. Also for off-label indications like bipolar depression, for anxiety. We have some off-label treatments for OCD, things like that. We are willing to consider, and that is a patient-by-patient assessment, and we always describe potential risks and benefits. And again, unfortunately, usually the issue with off-label treatments is that they're a little more expensive because insurance won't cover it. But we do our best to get these treatments to people who need them. Something to consider, as we're talking about treatment-resistant patients and multi-medication failure situations, I really think this is a misleading term that we're using. And treatment-resistant depression is one of the biggest buzzwords in mental health in the 2020s. I mean, it's hard to open up a medical journal and not see something about treatment-resistant depression. I don't know what I think about treatment-resistant depression, and I probably treat more treatment-resistant depression than just about anybody in Atlanta. I've been treating this, as sort of my clinical preference since I was in residency. I don't know how to define it, and I'm not exactly sure what it means. So if I don't know those things, I think you can probably imagine that it is a little bit tough to pin down. It's not that we can't define it. There are standard definitions that include anywhere between, again, 2 and 3 treatment failures typically that define someone as treatment resistant. But what I can tell you is that it is extremely rare for a patient to come to us and say, I have treatment resistant depression. This is in TMS, it's in our Skyland Trail Intensive Services Program, it's in outpatient work. It is very rare for them to come in and say, I have treatment resistant depression, and for us to not be able to find some secondary reason why they are not getting better in their depression treatment. And that's different. I think that, when somebody comes in and you look at them and say, wow, this is just depression. It is solely depression. It is just a version of depression that will not respond to medications. That is, I think, I think that's what people imagine treatment-resistant depression to be. But usually treatment-resistant depression means multifactorial depression. So trends in our population and the TMS population across the board, one of the most common things we see is just people who come in saying, wow, I'm really depressed and I cannot get better. My meds are not working. And you sit with them and you're like, wow, I hear that. And I also feel from you an incredible amount of anxiety that is not being addressed right now. And it is very hard to feel well from a mood standpoint if you are very anxious. So we see a lot of undertreated anxiety disorders, trauma and the manifestations of trauma, people with, again, PTSD, frankly, or even just, some of the unfortunate kind of coping deficits that come from being subjected to trauma over time, in the version of personality disorders or even just traits or kind of other conditions where, people really struggle to cope and maintain resilience effectively. I will not go down this pathway because, again, this is an entire second talk for me, or now I guess a third talk for us. But I will say that the prevalence of personality disorders and traits of personality disorders driving mental health issues in the 2020s is going through the roof. And again, I have many hypotheses for why that is, and I think a lot of them are validated at this point. But suffice to say that we are becoming less connected to one another. We are spending more time thinking about our own condition and what's going on inside our own selves and our own lives. And that is a state that tends to drive what we typically describe as personality, maladaptive personality characteristics, and frankly, sometimes personality disorders. And that's such an issue, and it's something that I think we need to be addressing systematically and systemically. Substance use disorders. So, I mean, again, the one that we see more than anything is THC at this point. So people who are using marijuana and they're convinced it's helping their anxiety and their mood. And we have incredibly compelling clinical evidence to suggest that it does not do that. It actually makes people with depressive histories and histories of anxiety more prone to those symptoms. It makes them harder to treat. It makes them relapse more frequently, not to mention the obviously horrific things that can happen with people with psychotic disorders or bipolar disorder, for example, when they use drugs. Alcohol, I think, again, alcoholism is an alcohol use disorder, to say it more properly, is an epidemic in 2020s. I think that this is one of the most concerning areas of data to come out in mental health in the last few years has been the rising rate of alcohol abuse and misuse. So again, we always, really dig in on these things because most people come in and they're genuinely truthful when they say that, they don't think they have an alcohol problem or they don't think they have a marijuana problem or any other kind of drug problem. But we need to dig in and ask what they're actually doing and what's going in their body any given day, week, month, because at some level, we know more often than people know about the effects of those substances on our brain neurophysiology. And then again, I don't want to harp on this too much. And certainly most of the patients we see in TMS are coming from great providers who are providing very high level evidence-based care to their patients. But it is becoming more and more common that we are seeing providers who have a bit less training or who don't treat resistant conditions very regularly, just consistently kind of underdosing the medications. We see a lot of people come in, and I unfortunately tell them, hey, TMS could work, but I also think you could probably just try to increase your dose on your antidepressant because you're nowhere near maxed out on that. And there's a few other things I'd probably try first. Not using augmentation strategies effectively. And then, going back to my initial point, just lack of emphasis on the role of psychotherapy in modulating these conditions. I mean, again, it's just, people wonder, especially, I feel better initially, but then I keep getting worse, and my medication stops working. I don't know that there's a lot of great evidence to suggest that medications just stop working. I think a few things happen. One of which is symptoms become more severe, and that certainly can leave people prone to relapse if their medications are not dosed effectively to treat that new level of depression. But often what we see is that people have not changed the behaviors and the narrative in their life that tend to drive them back into that depressive hole repeatedly. Contraindications of TMS, so who can't do it? The only hard stop on TMS is metal implants or metal devices within 30 centimeters of the magnet. And there are a few different distances you'll see based on whether you're looking at manufacturer or FDA or just clinical standards, but that's a general rule of thumb there. Basically, you can't have anything electrical or metal in your upper chest or head, certainly. And what matters is whether they're ferromagnetic or not, meaning whether they will respond to magnetic impulse. And again, there are many metals that are not. Things like steel and iron-based metals, traditionally, and those are the ones you think about as being the most ferromagnetic. Things like titanium that are used in most implanted devices at this point. Skull fracture repair plates are often titanium. That is a non-ferromagnetic metal. So you are okay if you've had titanium implanted somewhere, but we do need to be sure about that. We need to know what's in that implant if you've had an injury or something in your head or neck. If you have a spine stabilizing rod or something like that in your upper spine, we need to know what's in that rod. History of seizures or epilepsy. So one of the things that can happen, again, we'll talk about this more, is that whenever you stimulate the cortex directly, you can generate a seizure. This is what we do in ECT. It is extremely rare in TMS, but we do know that people with a history of epilepsy have a greater risk of having seizure when their cortex is stimulated, especially if they're not medicated appropriately. So we do screen for that. It is not a hard stop, but it is something insurance companies typically will not approve. Again, that's a risk-benefit discussion for us with patients if they still want to do TMS. History of mania is a contraindication, a relative contraindication, because like other antidepressant treatments, TMS can induce mania in patients who are not mood stabilized effectively. History of head trauma, meningitis, encephalitis, those are both just predisposing factors to seizure, as is withdrawal from benzodiazepines or alcohol. And then history of psychosis is a relative contraindication by the insurance companies only at this point, as far as I'm concerned. It is less effective. TMS is less effective in depressed patients who also have psychosis or have had a history of psychosis. That is, in my opinion, again, this is again, based in both neurobiological theory and also some data, we know that patients who have depression with psychosis are less likely to respond to any treatment largely. So again, the more severe your depression is, and we think about psychosis as a very severe manifestation of depression, people who have severe depression are less likely to respond to any given treatment. So it seems a little bit counterintuitive that we would remove one of the most effective treatments we have, if not the most effective treatment we have for depression, for the patients who need it the most. Again, that's a battle I'll fight with the insurance companies every time. This is how we actually begin TMS. So what we need to do is find out where that spot is, that dorsolateral prefrontal cortex that we want to stimulate. So we call this the motor threshold. It's the amount of power we need to be able to stimulate that area of the brain. We first measure that by actually measuring the amount of power we need to generate a finger twitch via the motor strip. So there's an area sort of right a little further back on the head, about 6 centimeters or so back of the treatment area, on the motor strip, the area that controls our motor function, where we can stimulate the brain using a handheld stimulation device and actually watch the patient's finger move when we reach enough power to actually get that cortex stimulated. So it essentially gives us a number to work off of, and then we We use a correction factor for how much power is needed to then stimulate the prefrontal cortex as compared to the motor strip. Again, it's about 5.5, 6 centimeters in front of where we get that motor twitch. We use a method called beam now, which is a more customized method of locating the treatment that is designed to take in the individual's head size into account when we pick the area, which seems intuitive, right? I mean, not everyone's brain is the same size, therefore just moving 5.5 centimeters forward from the finger twitch as we used to, probably not really accounting for the individual differences in brain size and head size. So we use that method, which has been shown to be a little more accurate in defining that area that we need to treat. The standard course of TMS is 5 sessions a week for 6 weeks, followed by a 6-session taper. So Monday through Friday for most people. A lot of people ask, what if I'm going to have to miss a day for work or, medical procedure, something like that. We're less worried about day to day, consistency, meaning most people miss a day or two. We don't come in on holidays, etc. We do try to tell people not to take long vacations in the middle of TMS or to plan their TMS around vacations if they can help it. We monitor scales throughout to track depression and anxiety. Depression is a standard thing that is required for TMS treatment. We add on anxiety at Skyland Trail because I think it is something that is important to track for all the reasons we've mentioned, and also because at some level we know that TMS helps with anxiety. And we're trying to prove that it's a treatment that we should be receiving FDA approval, and we should be able to treat patients under their insurance plans for anxiety as well. We measure progress that helps us make adjustments and track and help patients understand where they are and what we expect to happen going forward. Again, you can stimulate unilaterally or bilaterally. There's also treatments for OCD that you can add on. Again, we'll mention that in a bit. But as we mentioned earlier, we're stimulating the left side of that dorsolateral prefrontal cortex, and we're inhibiting that right side of the dorsolateral prefrontal cortex in TMS. And we can customize this to individual patients and frankly, sometimes to individual people's insurance plans because they do have different requirements for what we do or don't do. Repetitive TMS, which is sort of the original TMS, you'll see RTMS is the abbreviation there. You got a few different options, one of which is high frequency 10 hertz stimulation at the left dorsolateral. You also have, again, another highly evidence-based and effective treatment that many people use independently, which is low frequency 1 hertz treatment at the right dorsolateral prefrontal cortex, as well as a low frequency treatment at the supplemental motor area that we can use as an evidence-based treatment for OCD. That is something we can add on at Skyland Trail. We do that for our patients if they have OCD, if they're experiencing symptoms of OCD that are also complicating their picture. What has really been a huge advance for TMS, and especially for us here at Skyland, has been the inclusion of theta burst stimulation as an FDA-approved treatment, again, back in 2019. So this is a newer, higher tech way of delivering TMS. It involves 50 hertz triplets delivered at a 5 hertz interval. So it's basically bursts of bursts. It is a, again, very physiologically oriented treatment that is meant to more closely mimic endogenous brain function. We use intermittent treatment at the left side. That's the sort of stimulating version of that. And then continuous theta burst, which kind of counterintuitively is the inhibitory treatment on the right side. Again, we think that theta burst may have a greater ability to induce long-term synaptic potentiation. So again, the durability of this treatment might be a little bit better. This is all putative at this point. The data is not strong on this, so I'm just saying this is kind of what we're thinking may be the case. It's certainly no worse than repetitive TMS and probably a bit better. It is more efficient. We get our sessions done in about 3 minutes unilaterally or 18 minutes bilaterally, as opposed to 25 to 40 minutes for the old RTMS treatments. Patients find it more tolerable, both in terms of time and just the way it feels on the scalp. And then again, what we can say is that it's not necessarily more effective, but there's no significant difference in effectiveness between theta burst and RTMS based on, again, studies with thousands of patients at this point. We know that accelerated protocols are effective too for those of you that might see a provider or have patients who see a provider who does repetitive TMS. So going back to studies from Neuronetics, which is a device manufacturer, we know that it's more about the dose of TMS that's delivered and that there are ways to condense the protocol so the patients don't have to sit in the chair quite as long. And again, these sessions used to take 40 plus minutes. The DASH protocol, back in the late 2010s was designed to really cut down on the time, and it was shown that there was no change in effectiveness or safety. Patients will come in, they'll recline in the chair. Their head is immobilized, as you saw from that picture of our machine. There's basically sort of a U-shaped kind of cupping, very comfortable but very stable head support there on the chair. As long as they keep their head stable and don't fall asleep, those are really the two things we ask them to do. A lot of patients will sit there and just sort of meditate or do mindfulness activities for those 15 to 18 minutes we have them in the chair. Many will read, some will use their phones. But again, the real key is that they stay awake and don't move their head. It used to be a much louder treatment with the old technology. The new machines are very efficient, and therefore the kind of clicking sound that's generated by the machine is much more tolerable. We do recommend earplugs for patients. That's an FDA required recommendation. We have those for every patient. Side effect wise, this is very, very well tolerated. We've had close to 300 patients do TMS now at Skyland Trail, and only 2 patients have discontinued treatment across that entire set of patients, due to tolerability issues. And those were issues that were related to chronic pain conditions that were leaving the patients very unable to kind of tolerate any type of discomfort, again, due to really unfortunate chronic conditions, but usually very well tolerated. Again, patients are usually raving to each other about how easy it is and how it's so much less painful than they thought it would be, et cetera, et cetera. It gets easier over time too. Patients will have a little bit of discomfort at the outset, sort of at that site on the scalp where we're stimulating. And then the scalp very quickly accommodates and, again, starts to write that stimulation off as background noise, and the pain starts to diminish pretty quickly, usually within the first week or so. Headache, not uncommon. 20 to 30% of patients will report a headache. Again, usually very time limited and very mild. It's usually in the plus or minus. Do you want to take a Tylenol or ibuprofen type of category of headaches? Not prone to worsening migraines or anything of that capacity. Neck pain, usually just due to having to position people's necks, and this is more for people who have underlying neck issues. Again, we have a very comfortable chair. I think there are some chairs in the past that were less comfortable, and that's where you'd see the neck pain reported. Again, great data, thousands and thousands of trials at this point about safety, and with tens to hundreds of thousands of patients. Patients can return to work or other activities immediately following the session. That's a really great advance from where we were with electroconvulsive therapy, where you're having to. Again, I mentioned electroconvulsive therapy because it's really the only other treatment that's on par in terms of effectiveness with TMS. But ECT, the hard thing is you have to undergo anesthesia. You need to have a ride to and from the treatment, and frankly, no one's looking to go back to work after they have an ECT session. We have many professionals who come in for outpatient TMS, come into the chair, sit with us for 15 or 20 minutes, and then go right back to work. The amount of time that it takes patients to improve varies pretty heavily, but I would say the bulk is within 3 or 4 weeks, again, for all the reasons we've mentioned earlier. Patients should continue their medications and psychotherapy for best effect. It is not that they have to, meaning we do have some patients who have looked at TMS as a monomodality treatment for depression. The best response for patients who have treatment-resistant depression, meaning they've tried a few different treatments and they haven't worked well or haven't gotten them where they want to be, is to continue the medications and therapy. It doesn't necessarily mean they have to continue their full dose forever, but we do know, that again, having patients achieve remission and then continue their medications at their current dose for 6 months to a year significantly reduces relapse rates in those patients. And that's what this is all about, right? It's great to get better for 6 months. It's ideal to get better continuously. The great thing about TMS is it's getting covered by more and more health insurance plans. Virtually every major insurance company has a TMS policy at this point. I can't think of one that doesn't. Again, the criteria vary, and the bigger companies that obviously have a lot more patients covered and lives covered under their policies tend to update their policies a little more actively than some of the smaller the companies. But in general, it's very well covered. Other things to think about, and this is something we screen for in every patient. So there is a risk of seizure, as we mentioned, but note the numbers here: 1 in 1,000 patients, 1 in 30,000 sessions. Those are probably the most aggressive numbers you're ever going to see. More recent data suggests that it may be closer to 1 in 5 or 1 in 10,000. This is lower than the seizure risk for many medications for which we never talk about seizures, or we don't say in a standard way talk about seizures. So just to put it into context, this is a very low seizure risk. Seizure would occur during the treatment, meaning in the chair. So every TMS provider has to be equipped to treat a seizure. They are typically more scary than they are dangerous. But again, we have never had one. I suspect we will never have a seizure in TMS at Skyland Trail. If it were to happen, we are equipped to treat it. And, it's something that we obviously talk to every patient about and help them understand their risk. Some patients who have a tendency to have vasovagal syncope will have a sort of fainting or falling out episode. We've had one person have that happen where they just, the whole sitting in the chair, having the magnet on their head was just a little more than they could handle from a psychological perspective, and they did faint, but they did great. They got right back in the chair, and we continued treatment. That is not a reason to stop TMS. You have seen reports, and I still mention this even though this data is kind of going away over time, but you will see this idea that patients may get more anxious before they start to get better. We have not seen that clinically. Our data does not suggest that. I think historically, when unilateral stimulatory treatment was used at the left dorsolateral prefrontal cortex, there may have been some crossover effect that was making patients prone to experiencing a little bit of anxiety. Again, it may just be sort of that nocebo kind of, the idea of being in a new treatment and having something that's mildly painful on your head can make people feel more anxious type of thing. Not real sure. There's not a great mechanism for that, but it is something people have reported. In those reports, I think it's just important to note that the anxiety would diminish and return to baseline or improve over the course of treatment, even if it was acknowledged at the outset. No associated amnesia or cognitive issues, memory issues to deal with here, which is great. Effectiveness-wise, so we've had at this point over 30 sham-controlled large-scale trials demonstrating effectiveness and safety. Again, thousands of trials overall, but when you're talking about just those types of, really hardcore baseline FDA approval generating trials where you have a sham treatment versus an active treatment, this is a large number of sham-controlled trials for TMS, and they've all demonstrated the effectiveness and safety as a group. So, commonly cited, number that you'll hear, statistics that you'll hear, it's still on some people's TMS websites, about 50% response rate, about a third of people were remitting. Again, response is 50% reduction in symptoms from start to finish. Remission is a set point on each scale. These are not bad numbers to keep in mind in the sense that they're still far higher than what we would expect based on our STAR-D data for these patients that we looked at earlier for patients who are on their third or fourth medication. But suffice to say that there are much better data that are newer, and we'll show you some of that here. So probably the best study that you see in terms of most patients and greatest amount of data was this neurogenetic study, again, by a device manufacturer conducted between 2016 and 2019, still an analysis to some degree, but you're looking at, based on patient report scales, something like a 70% response rate and a 36% remission rate. With physician report scales, which tend to be a bit more accurate, 83% response rate, 63% remission rate, 62%, I should say. Either way, much higher numbers, obviously, than what we just looked at. I'd really like us to change the narrative about that half and a third into something more like 70 or 80% and 30 or 40% upwards of those numbers. As you see in that CGI data, probably 60+% of patients in a lot of different TMS practices will respond to TMS, will remit with TMS. Here's our results. So I get to brag a bit on this. These, as you'll notice, are not far off of, and look at that 84 and 63, not far off of the CGIS data there, actually quite close. So it's not that these are completely unique results with Skyland Trail. They are great results, though. I will give us a bit of credit because, whether it's our intensive services patients who are going through our program, and obviously we're doing very high level medication management, psychotherapy, other behavioral and adjunctive interventions that are evidence-based, or it's even the outpatients we consult on. Again, whenever I talk to someone about TMS, I always include a discussion of psychotherapy and medication management, all the other things they can do to get better, like nutrition, exercise, sleep, all the things that really should be first-line treatments for anyone with mental health conditions. We've got pretty high numbers, especially when you compare it to where they would be given the STAR-D data if they were just to try one more medication. Average symptom reduction in the Montgomery-Åsberg Depression Rating Scale, average symptom reduction of 70%. That includes patients who did not respond. So that's all patients, not just the ones who did well. And if you look at the scale on the bottom, you can just get this visualized a little bit. If you talk about any reduction in symptoms with TMS, 99 patients had achieved some level of improvement. So this is something like 205 out of 208 patients were lower in terms of the depression scale than where they started. 84% of our patients, again, achieved a response of 50% better or more, 63% in remission, And then 1% of patients either stayed the same or got worse in terms of their symptoms from TMS. These are numbers most people will accept. The other thing about TMS is durability. So again, we look back at, especially at that Dunner study about, the longevity of effective treatments. Again, where, less than 10% of people would achieve response at a year and sustain response at a year. Here you're looking at STAR-T data again. You've got the actual remission data for the initial treatment on the left column, and then you've got the continuation phase, so out at a year plus on the right. That column on the right shows you the rate of relapse, so the number of patients who then experience another depressive episode subsequently. And just look how high those numbers are. I mean, again, this is really unfortunate data, and I'm glad patients don't see this data. I don't describe this to them frequently because it's so prognostically concerning, and I don't want anybody to be overly concerned that they're not going to do well. But I mean, by the time you're at 3 or 4 medication trials of adequate dose and duration, you're upwards of 60% in terms of your chance of having a relapse in a relatively early date. And that is, no pun intended, so depressing to look at. And I think it's just another point of evidence of why we need a treatment like TMS. When you look at TMS, again, many studies looking at the durability of response, and it looks like these response rates will continue out at a year plus for at least half the patients. And what we see clinically, and that's a sustained rate of significant improvement. What we see clinically, again, this is not direct data but experience, is that very few patients, relatively speaking, who have done TMS with us in the Atlanta area need to come back for treatment. It's probably somewhere in the 10 to 15% range. So we tell everyone when they finish the Skyland Trail, please, let's stay in touch with your psychiatrist. I'll talk to them. And if you feel like your symptoms are coming back, please get back in here as soon as you can. And we will restart your treatment and get you back to your remission point or response point, wherever you were, or even better. And let's just do it early. Let's do it often. Let's make sure we stay on top of your depression so it doesn't get too deep. And we just don't get that many calls. Maintenance treatments are likely to enhance durability. There hasn't been one clearly defined treatment, which is why we don't have FDA approval yet. But most people do something like 1 session every 2 weeks. That's our most commonly used protocol. Again, there's 3 real key ways of looking at maintenance. One of which is just to kind of prolong the initial acute phase TMS and to kind of taper off slowly over the course of time. That's kind of the ECT model. Then there are, some people will use planned boosters, where even if a patient hasn't relapsed necessarily, they will have them come back for treatment just to kind of sustain the effect. Watchful waiting is what most people do. It's what we do, which is if someone does well in TMS, we don't schedule them to come back at any interval. What we do is tell them, just like I mentioned, to stay on top of it. If you start to feel your symptoms come back, especially if they last for a week or 2 or longer or feel severe, let us know, and we will get you back in for treatment. Based on how long it took for them to relapse and how hard it is to retreat them, we will decide whether or not we want to do an off-label maintenance treatment. Again, evidence-based, but off-label, meaning insurance typically doesn't cover it. But for many people, we will say if you've relapsed very quickly, or if you have a severe relapse, it is worth having you come back, even if you have to pay a little bit out of pocket, to make sure that we try to keep that at bay and keep you in a state of high level functioning. So on to some interesting stuff, and just looking at our time here, I want to try to save at least 15 minutes or so for questions. So what you got here is a stylized image of the connectome. And the connectome is this concept that goes back to what we were talking about earlier, where what we are more interested in than just sheer serotonin levels or norepinephrine levels, or especially when you think about claims that we can just look at one spot on the brain with neuroimaging and decide whether someone's depressed or not. I think that there are ways, again, as we've mentioned, to use functional MRI to really look at some of the functioning and metabolism and get a sense of whether someone's depressed. But really, we know it's so much more complex. It's about these networks and how they connect to each other. And what you're seeing here is, again, tractography, where you have essentially a heat map of the different connections between areas of the brain. And it's color coded based on the intensity of the connection. And this is how we measure systems and how they function within the brain. The new frontiers in TMS are largely oriented around new treatment protocols, so new ways to deliver TMS or new sites, different frequencies, which frequencies work best at which areas for which conditions. And then again, just new indications, so different conditions we can treat with TMS, or in the future, likely ways we can maybe enhance performance. I mean, there's already some cognitive enhancement research being done where, again, it helps with executive functioning, anti-ADHD treatment. Theta bursts in particular, a lot of great research, and something you've seen, frankly, on Sunday morning news. This data has been displayed. It's been in many media sources, but the SAINT protocol, which is a Stanford specific protocol, and the general concept of accelerated theta burst TMS, where patients are receiving multiple sessions per day in order to accelerate the response. Because again, we do believe it's largely dose oriented. There is a wait time that you have to employ in order to allow the brain to respond to multiple treatments. But in this case, you've got with Nolan Williams and the Stanford group's research on SAINT, you've got patients who were doing 10 sessions a day, spaced by at least an hour over the course of 5 days, with MRI guided placement of the magnet. And at that point, a really, really outstanding number there. Close to 91% of patients achieving remission overall, with results as early as 3 days. So you can imagine how powerful this is for a population like an inpatient psychiatric unit, where you have patients who can do 10 sessions a day because they don't have too much else to do, luckily, or even in a place like Skyland Trail, where we can do multiple sessions per day because we have patients with us, near the magnet, doing their residential treatment or their day treatment. There is now an FDA-approved device designed to do the accelerated MRI-guided neuromodulation in an outpatient setting. Clinical feasibility is tough. It is very expensive. It's a little bit impractical to have patients around that long unless they're usually in a very controlled setting like inpatient or residential. But again, a great hope for the future that we can do more accelerated protocols, and then insurance will cover it soon. John Downer's group in Toronto has really established this idea that accelerated TMS, even beyond just the specific SAINT protocol, Stanford's protocol, is effective as well. So again, response and remission rates very quickly by doing multiple sessions per day over a shorter period. These numbers are not quite as high as some of the other numbers, but again, if you look at their kind of extension data, you do see people continue to improve. It's safe, it's effective. It's a great method of treating people who are sick and need to get better quickly, or who don't have as much time to come back repeatedly day after day for 6 to 9 weeks, as we described. The connectome, and thinking about how we, again, view the brain. So Michael Fox and his group at Harvard have really taken this to a new level in terms of the research. Again, the quote from his work is that neurologic and psychiatric symptoms correspond more closely to networks of connected regions. We've hit this, multiple times now, so I won't belabor this too much. But, just this concept that, again, lesions in different locations. So in other words, we have two people, let's say, we take a study where, patients have brain injury. And for some reason, we see that two people who have brain injuries in totally different spots in their brain end up with the same symptom set. That doesn't really make sense based on our traditional sense of one location, one symptom. But because they're in the same network, we can explain why they experience the same symptom with different lesions. So that is something that really is, a nice form of face validity for that concept, and there is extensive research to support that. We can tailor our TMS and other interventional treatments like deep brain stimulation to specific neural endophenotypes. So these different sort of brain manifestations. If we talk about phenotypes, we talk about the actual symptoms and the actual manifested personality and brain functioning that you see in a person, not just the data and the MRI, but how does this person look? How do they function? How do they behave? We can categorize people based on their issues or their functional deficits or their functional strengths, and we can look at the different networks that are implicated, and then we can actually target TMS and other interventions to those networks. And it also will help us figure out who's going to be more likely to respond or who's going to be less likely to respond at our traditional sites, at new sites, but really, again, just hammering in this idea that the brain and its system of networks is what this is all about, and that we can get really customized in terms of TMS for people if we understand that. Again, back to that slide, just reiterating, we've got many different networks, and all of these can be targeted with TMS to treat whatever condition or sort of circuit and symptom function you see from the network. We have multiple elements of the limbic system involved. We have, again, tried many different sites and different methods of accessing the brain to treat depression. We do know that different symptom clusters tend to associate with different circuits. And Shan Siddiqui and his group, again, he's up there with Mike Fox at Harvard, looking at different sites, and this was kind of I would argue the first really compelling set of studies that showed that if you treat people with different types of depression at different locations, you get better or worse treatment based on their sort of manifestation of depression. So he looked largely and initially, and there's been lots of research since this, but initially it was patients who are more classically melancholically depressed versus patients who are more anxious, activated depression, agitated depression, and basically locating the coil in a different place will treat these two different groups more effectively. Including electroencephalograms in order to both locate the dorsolateral prefrontal cortex and other sites in the brain, but also to check in real time at how the TMS procedure is working, making sure we're simulating the right spot, making sure that there's responses that we're expecting in terms of that network response to TMS to see that it's working. This is a little bit more in the future type, but there are many research studies going on right now, and some people are actually applying this clinically via devices like the one you see there. And then, again, some more thoughts about neuronavigation going forward. How do we get this magnet positioned correctly so that we stimulate the right spot consistently and effectively? Does that change over time in an individual patient? Probably not, but we want to know the answer to that. And again, many of the new machines that we're looking at include devices that both help with neuronavigation and placement, and also ensure that good contact is occurring and that good stimulation is occurring. The bottom line is, however you do it, you need a system in place to make sure that the magnet is placed consistently and that patients are receiving the amount of pulses we think they're receiving from the machine. Really interesting research around neurocardiac guided TMS, which is essentially timing TMS so that it is functionally accounting for the different cycles of the cardiovascular system. So basically heartbeat and sort of the cardiac rhythm that you'd see in an EKG. We know that stimulating at different points in sort of that EKG rhythm can have different effects based on a variety of different systems, including, again, sympathetic, parasympathetic tone, and that may affect the effectiveness of TMS. This seems to have stalled out just a bit in terms of the amount of hope that it's going to be the next thing in TMS, partially because it's just so difficult to conduct, but really just fascinating to think about how the whole body contributes to these symptoms and how we really can treat in a way that reflects the whole body's involvement. Deep TMS. So, and again, I'm going to touch on this briefly just to make sure we have enough time here to get some questions in. But deep TMS is a treatment that's specific to OCD. It's one machine initially by BrainsWay was approved to treat OCD. There are now multiple machines that are FDA approved to treat OCD. It's just a slightly different type of TMS that is designed specifically for OCD again, and good responses. These are lower numbers than we just saw for depression response with TMS, but OCD is traditionally a bit harder to treat, and these are very good numbers. One of the things I always say though when patients come with OCD and ask about TMS for OCD is, have you done the psychotherapy that is incredibly evidence-based for OCD? Because that has much higher numbers than these ones we're seeing here. So, usually the good candidates for deep TMS for OCD are the ones who have tried exposure response prevention or other types of evidence-based psychotherapies for OCD and medications for OCD and have not gotten the response they want. There's a picture of the machine just so you can get a sense of what a deep TMS coil looks like, kind of like an upside down trash can scenario going on there. And it is a little less directly targeted, but effective as we saw with those data. And this is an area where, gosh, I would love to just have some advances, and we are fighting hard on the insurance front for this and on the research front. TMS for kids and adolescents, as we showed, this is such a good group to target because we don't love necessarily the effects that medications have on kids kind of across the board. I will say this, if you have children and patients or your own children, family members who are depressed, anxious, who are have concerns for psychosis or mania, any symptom, ADHD, it is it is a risk benefit discussion, and for most of these patients, especially if they're in the moderate to severe range, any effects of the medication are far outweighed by the negative effects of having the brain in an untreated condition over time. It is really important to get these patients under control, and we try to use medications at as low of an effective dose as possible for as short a time as possible. But I will say that again, evidence suggests that patients, even young patients, really need to be treated effectively and assertively so that they can both not manifest the long-term brain consequences of having untreated conditions over time, but also just so that they don't have to suffer any longer than they need to. I think the meta-analyses on adolescent TMS are incredibly compelling. Very high response rates. Again, similar rates of response to adults. Very well tolerated, very safe. The problem is that kids respond to placebo at a very high rate. So you've got upwards of 35% of patients responding to a placebo TMS, which makes it hard to generate that separation you typically need for FDA approval. That is really the limiting factor at this point, and we're working on that as an industry here. Again, really exciting data on schizophrenia. So anybody who treats psychosis or who knows about psychosis treatment, schizophrenia treatment in particular, knows that negative symptoms, so that social withdrawal, the cognitive dysfunction, the kind of isolation and just sort of flattening of people's affect that occurs with schizophrenia over time, is one of the hardest things to treat. It's one of the most upsetting components of schizophrenia. It's often not that hard to control the hallucinations, delusions. Unfortunately, people really experience a lot of dysfunction in their lives because they become withdrawn and their cognitive function starts to go. There's some evidence that TMS may help with the negative symptoms of schizophrenia, which largely has no truly effective treatments at this point. So this would be groundbreaking. Moderate effect size is a very high effect size for negative symptoms of schizophrenia compared to other treatments. TMS for Alzheimer's disease. So, looking at stabilizing that deterioration rate and actually helping with functionality in patients with Alzheimer's disease. Again, this is just another treatment in addition to the medications that really might help stall some of those symptoms. It's not going to cure Alzheimer's disease, but it is going to help these people function better for longer. And more research in the works on all the topics you see here. I expect, in the next 5 to 10 years, multiple additional FDA approvals, especially for PTSD, anxiety. Hopefully we'll get bipolar disorder eventually and some of these other conditions. Good data on eating disorders, especially mood and eating disorders. And then just, again, thinking about addiction as an epidemic in the 2020s, there are many different treatment sites and different treatment modalities with TMS that seem to have great data to support their treatment in various substance use disorders. And they're relatively close, speaking to the research and most likely to FDA approval. So we'll really look for those to help support our patients with addiction or with dual diagnosis status. But really the take home here is that TMS is a very safe, very well tolerated, and very effective treatment for especially resistant depression. Theta bursts in our quicker, more efficient protocol that we use at Skyland Trail, and many people are using both in clinic and in research, has improved efficiency and tolerability. And it may lead to better effects over time. We need more data to suggest that, but that is certainly the hope. The relapse rates for depression are relatively low compared to meds and therapy. And we also have maintenance protocols or preservation protocols we can use to prolong the effect. Improving targeting and finding more options for treatment are really the future of TMS. Again, making sure we understand which diseases are treated most effectively in which areas, and then finding a way to ensure that we deliver the magnetic pulse to that area. We're getting better equipment. We're getting better, overall technology. We're finding better ways to monitor treatment so that we can ensure that we are really targeting the area we think we're targeting. And then just to mention that, again, this is a constantly evolving field. The evidence base and the clinical applications for these treatments is just, hundreds of articles released every month. And it's really encouraging to see how much stake has been put in TMS as a safe and effective treatment and how much research money is going towards TMS, because this is something that it's not inconceivable at all to think that TMS could be in the majority of psychiatrists' offices in the next 10 or 20 years, and that we could be treating people more effectively and avoiding long-term dysfunction. Again, I think one of the most compelling things we think about with TMS is, again, helping people not stay depressed as long as they've stayed depressed. We really worry about patients who are depressed for 3, 6 months, a year, 2 years, beyond, because it gets harder and harder to treat as each month goes by and they become more and more dysfunctional, and it has an impact on the brain that we know is negative. But also because these patients who are partially treated tend to really do well with TMS. So, as much as it's, 50% improvement in TMS, a 50% improvement in depression feels great to that person. If they came in severe and end up in the mild to moderate range, that feels great to them, relatively speaking. We know that it's a totally different biophysiological state when someone reaches remission. It reduces inflammation levels. It allows the brain to rest and recover and really function at its best, which, again, obviously makes the patient feel better. That's literally what we're measuring. But it also reduces the likelihood that they will relapse and it increases the likelihood that they will function at their best for long periods of time. So our target in treating depression and other conditions needs to be remission. And as you can see, with TMS is a procedure that has very high remission rates, especially in patients who are struggling to get that last leg of the race completed. So really hopeful about how that can help our patients going forward, and just thrilled to see how we can get this into more providers' hands and out to more patients over time. So thank you very much. I'll just quickly run through all the different research that was included in this talk, and I will be happy to take questions here. I know we've had a number in the chat and in the Q&A section. So I know, Molly, you've been taking a look, and I'll be happy to answer some.
Yeah, thank you so much, Dr. Hunter. This was very interesting and some exciting new research coming out. You did receive a ton of questions, so I apologize if we can't get to all of them. I tried to group them together based on some common themes that were coming up. So let's go ahead and get started on those. The first kind of group is some potential patients. What about people with braces, metal dental implants, or metal fillings?
Yeah. The metal implants and sort of orthodontic hardware are not a concern for TMS. So that's something where many patients will ask, well, if I have earrings or piercings, or if I have braces or a retainer, not an issue. Largely non-ferromagnetic. The effect with TMS magnetic impulse is a slight heating effect. So what we're concerned about is if someone has a plate that's made of a ferromagnetic metal, and it's especially if it's in their brain or somewhere near the nervous system, is that we're going to heat that up and impact, obviously concerned about harming the brain in that way, or other body parts in that way. It's such a minor effect, even if there is something ferromagnetic in orthodontic hardware or in eyeglasses or something like that, patients would not notice it. So we are not worried about that.
Great. Is it safe to treat for cancer patients that are currently undergoing treatments?
That would be an individual assessment based on probably the seizure risk with any given chemotherapy or other type of treatments going on there. But there's no inherent reason why TMS wouldn't be effective. And in fact, again, if someone's depressed and is undergoing treatment and therefore is limited in the amount of medications they can try, that might be a great indication for TMS. Not aware of any great studies specifically with cancer patients, but we think about depression and cancer in a lot of ways as being similar to depression and other conditions too. So, as I mentioned earlier, treatment-resistant depression, in my mind, is multifactorial depression. And, that includes people who have difficult life circumstances, who have significant medical issues or treatments that are causing some depressive symptoms. The nice thing is it seems like most of these patients will get better with TMS. One of the most compelling bits of data we've seen in recent years is that we took patients in a study, we being psychiatry, not Skyland Trail specifically, but there was a study that looked at patients with borderline personality, and they took patients with BPD and major depression and patients with just major depression and compared their response to TMS. And shockingly, the groups did not separate in terms of their response, meaning you had as good of an effect in patients with BPD and major depression as you did in just the major depression patients, at least in terms of clinically significant difference. So, that is a stunning research point in a world where we always kind of assume that more diagnoses equals less likelihood of responding to treatment. So again, what we know is that there seems to be many people with depression who probably have multifactorial depression.
Interesting. You mentioned research coming out for Alzheimer's, but what should a clinician know before recommending TMS to a person with treatment-resistant depression who may also be exhibiting symptoms of dementia?
Yeah, it's a tougher thing to treat for sure. The neurocognitive processes that are going on in dementia conditions are a little more complicated than just depression alone. I think the main thing is that patients with Alzheimer's or other neurocognitively driven depression need to make sure that they're receiving good treatment for those primary conditions first. They need to have someone managing their Alzheimer's disease and taking advantage of all the different treatments we have. I say all the different treatments in a little bit of an optimistic way, and we know that what we're largely doing is slowing the progression of that disease, but making sure we cover first things first. Same with like Parkinson's disease, depression. You need to have your Parkinson's disease well managed before you start to jump into things like TMS. And it's true for many different conditions. Largely, when patients come in and they have medical conditions or other sort of psychiatric conditions, a lot of the conversations I have with them is, I just think maybe your primary thing's not being treated as effectively as it could be. And why don't we focus on that? And, sometimes we do TMS simultaneously. Sometimes I tell them to come back, and I'll talk with their doc and kind of coordinate and say, hey, there's actually more we could do for this person in another domain before we jump on a TMS.
Thank you. So some logistical questions about TMS. What type of professionals are able to run the TMS machine?
Yeah, so TMS requires, in most states and by most insurance plans at this point, a physician to conduct the consultation and then essentially do the first session where there's mapping and coil placement and those things. Also, it's assessing risk. It's having the risk benefit conversation, informed consent with patients about TMS. That requires, in most situations, an MD or a DO. In some situations, nurse practitioners or other extenders can also do that assessment. I think in many situations that is safe. It is a fairly straightforward conversation with most patients. The technicians, there's no standard licensure needs for that technician. In terms of clinical standards for the Clinical TMS Society and other groups that sort of oversee TMS globally, a formal training by the device manufacturer is typically required. So at Skyland Trail, all of our TMS technicians will undergo formal training with the people that made the machine and therefore know how to use it and operate it effectively. I also train them specifically. We have an additional degree of clinical standards at Skyland Trail where our lead technician has attended Clinical TMS Society formalized training. It's called Pulses. It is a course that is extensive in terms of the education and safety and monitoring and the teaching that goes on around TMS for that person. So Cassidy Fulbright, our lead TMS, who's our program manager at this point, has gone through the Pulses course. I recommend that for at least one person in every practice is going to do TMS. Sometimes the doc can get away with just doing it, but I think ultimately it's great if at least one or two technicians do that too.
There are often criticisms about older TMS systems versus the new technology. How much more effective are the newer systems? In other words, should the older models be avoided?
Yeah, I'm going to be really careful to make sure I don't misrepresent this too. I mean, there is not a clear separation in new technology versus old technology for effectiveness or safety. So, again, our TMS, which is still, again, this is the high frequency, low frequency TMS that takes a bit longer with the, less new machines, I should say. That is still very, very safe and very effective. And again, on par with Beta Burst. I think the main advantage with Beta Burst at this point, at least, is that it's quicker. And it's very quick. I mean, if a patient is not insurance dependent, I can come in, I can do a theta burst bilateral session in 4 minutes. So you can imagine how nice that is for, again, the multi-session situation where we're doing 5 or 10 sessions a day. It only takes a bit of time, but also for people that are in a rush and trying to get TMS on their lunch break or before or after work or, around, the time they need to grab the kids or whatever's going on in their lives. There's a lot of different applications where a quick session can really help out. But effectiveness wise, I mean, I think that there are many very reputable providers who still use our TMS. And again, insurance is a little slow to cover theta burst. So, we don't always get approval for theta burst. So therefore, in many cases, I need to do an RTMS protocol to make sure that insurance companies don't come back and bill the patients after seeing that we have not done, a protocol that fits their criteria. So, just to be totally transparent, what we typically do for most patients to get bilateral, we don't do bilateral theta burst because, again, theta burst is still viewed as FDA approved but non-medically necessary for patients. So what we'll do is we'll do the FDA approved left-sided intermittent theta burst protocol for the patient. And then in order to make sure that their insurance will cover it, we will do right side low frequency RTMS in the 1 hertz 15-minute session. That's why it takes 18 minutes to do our protocol. We want to make sure that their insurance covers it and the patients don't get stuck with a bill on the back end. So that's our usual protocol.
On that note, can you go into a little more depth about how it's determined which side of the brain to treat and how often bilateral treatment is recommended?
Yeah. The truth is that both left and right-sided treatments, as described earlier, are both evidence-based and FDA approved. So currently you've got, again, left-sided high-frequency, right-sided low-frequency RTMS, and you've got left-sided intermittent theta burst, all FDA approved to treat independently. Again, data seems to suggest that a combination, bilateral treatment seems to be more effective than either one individually. Our standard is to go with bilateral treatment for everyone, unless an exception dictates. So the vast majority of our patients receive bilateral TMS, as I mentioned. unless their plan happens to mention that it covers data burst, which is a few, especially Anthem plans. We're doing left side intermittent theta burst, right side low frequency RTMS. In some patients, their symptoms may dictate unilateral treatment. Often, and there's a little controversy about how much this is evidence-based versus how much of it's just kind of clinical feel, and I do want to be clear about the difference between those things. Many providers, if patients are extremely anxious or if they get agitated with TMS initially, will remove the high frequency treatment and just do right side low frequency treatment. Maybe a little bit less anxiety associated with that based on the literature. Hard to tell, but that is one of the key exceptions, is that if someone can't tolerate one treatment or the other, either because of discomfort or because of agitation, we might move to unilateral treatment.
Great, thank you. We got a lot of questions about TMS versus neurofeedback. Can you talk about the differentiation and your thoughts there?
Yeah. So kind of different modalities. So, a lot of the same, sort of thought processes that were going into this writing, and we're thinking about neurofeedback as a way to, kind of map what the brain's doing and use that as a way to monitor, where someone is at the moment, and also to make, typically some behavioral biological interventions to modulate that. TMS sort of does that in some ways. And, at this point, you're looking at, again, active EEG monitoring, which is often included in neurofeedback, in order to drive TMS placement, and in some ways in the future probably to control the way in which the pulses are delivered. So you're taking advantage of a lot of the same concepts. They're additive. I mean, and there's great evidence base to support neurofeedback for a number of different conditions, and we actually do some of that at Skyland Trail too. But two different treatments that are potentially could be combined to get an even better effect for patients.
Great. You talked about the research and the work. So a lot of people asked about specific things like PTSD, ADHD, which you touched on. One thing I didn't see on the list was autism spectrum disorder. Have there been any studies with people with that diagnosis?
I'll admit an area that I'm a little less versed in the current research on TMS, but I will say that there are a number of studies. I know that for certain. And largely what we see with treatments for autism spectrum, and this is true for some of the TMS studies as well, kind of maps onto what we were saying about Alzheimer's disease or other conditions. We can treat, because we think of the brain as a system of networks that all drive different symptom clusters or different conditions, we think about, depression in someone who has autism as, in many ways, probably very similar to people who are non-autistic and also have depression. So we can kind of treat that symptom with TMS, sort of like we treat executive dysfunction in schizophrenia. Again, treating autism itself, with neurodevelopmental diseases, with Alzheimer's disease and neurocognitive conditions, neuropsychiatric conditions. Unfortunately, what we're mostly looking at is functional improvement. We're not aware of a way to sort of reverse some of the effects that have happened, unfortunately, with some of these conditions. But what we do know is that a lot of, obviously, the impairment with autism is based in functionality. So if we can improve people's functionality by treating some of the symptoms they experience, in many cases we can really have them just do better in their lives and feel better. So we're really kind of targeting the symptoms that present themselves, and that's how we're thinking about psychiatry. It's not how the DSM directly, and as we diagnose and do research, unfortunately, we do need to lump into diseases, but we're thinking about symptom clusters as we think about treatments in many cases.
Great. We have time for one more question. A lot of people also asked, how would you recommend they find a TMS provider in their state? Also, kind of on that note, Skyland, if they are local, can you talk about the outpatient? Do they need to be inpatient to receive it, and kind of how that works here at Skyland?
I want to make sure I didn't forget that critical part of this whole process. So, yeah, I think at this point, finding a medical provider overall and kind of vetting their reputation is a little bit difficult. What I typically recommend is that you gather as much education via seminars like this or other literature about TMS as you can. I mean, I think largely these sort of patient and support system oriented talks like this are usually good enough. I don't think delving into the research is really essential. But if you start to see providers, and most TMS providers will now have websites. I mean, it's just because it's a higher tech treatment, because it's something that is also generating some good revenue for most clinics. They tend to market it pretty well, and they'll mention it on their website. Look and see, kind of how sophisticated their discussion of TMS looks. Whether or not some of the things that were mentioned in this webinar, for example, are included in terms of how it works. I look out for gimmicky types of websites. I think the number of times I've kind of directed patients away from websites that make extreme claims or that seem just a little bit hokey or a little bit oriented towards marketing more than actual treatment. Look at the credentials of your psychiatrist who's driving the program. So I mean, these are, it's not as easy as just looking at where they went to school, but some explanation of their credentialing and their experience with TMS. I think that if you ask providers, other psychiatrists, how would they select someone or what's the most important thing? I think a lot of it is that we do TMS regularly, meaning at Skyland Trail, we're doing TMS every day with 10 to 15 patients plus every single day. I think about TMS, every single week, multiple times per week. I do consultations regularly. That keeps you sharp. That keeps you on top of the research. That means that you're going to have the newest data and the newest treatments. Luckily, it's not evolving so fast that the actual clinical applications are changing rapidly, but you really want somebody who's paying attention to the evidence base and the new technologies that are coming out and making sure they're delivering the most evidence-based treatment possible. They should know the difference between unilateral and bilateral treatment, and they should explain why they do or don't use theta bursts. Like those types of questions, those should be pretty straightforward for a provider. And the good news is there's lots of providers. One way you can find them is you can go to the device manufacturer's website. So if you search TMS and find a TMS provider or something like that, or TMS in your area, you'll often see, whether it's MagStim or MagVenture or Neuronetics, they will have these TMS machine manufacturers will actually have all their docs who have those machines in a database where you can search them by location. Even just Googling at this point, though, you'll end up seeing a lot of facilities, and there are more facilities that are able to provide a little bit higher volume treatment at this point, which is great. I will mention that TMS and Skyland Trail is available as an outpatient procedure. So we both do it for our patients in the program, intensive services, but we also have just an outpatient referral-based TMS program. So really all that has to happen is that a physician has to provide a referral. We do require that the person's working with a psychiatrist and that psychiatrist can account for that person's eligibility. We are a consulting service. We don't take over the primary treatment of that patient, but we do the TMS in concert with their primary provider. So all they have to do, all anyone has to do is essentially call our office for additional information if they have someone they'd like to consider. Obviously, we're going to talk to the psychiatrist on the back end, so it'd probably be good to talk with your psychiatrist first and make sure that they feel like it's a good idea and that the eligibility is there. But really, our number, which I'm sure we can include here for everyone for outpatient TMS, just give us a call and we schedule free consultations. We do want to make sure we'll do some screening just to make sure someone's a viable candidate. But anyone's welcome to call if they feel like their person would be a good candidate for TMS.
Thank you, Dr. Hunter, for the really informative presentation. We really appreciate all the new knowledge on TMS. I think everybody learned a lot. And I want to share that number before I forget. And Molly, you can even put it in the chat too. The number for our clinic to access the TMS service is 404-709-3177. So feel free to reach out to us for that. And thanks for sharing.
Add one update there, Julie, real quick. I'm so sorry. We have a new updated TMS number. So actually,
okay.
Scratch that last one, guys.
Sorry about that.
No problem. This is new. I should have gotten that to you ahead of time. The number for our TMS program directly is 678-686-5972. So again, 678-686-5972. That'll get you directly to Cassidy Fulbright, the program manager, and she will shepherd you into the program. Thanks, Julie.